The Gairdner Early Career Investigator Program honors exceptional career researchers across Canada who are already shaping the future of science and health. Dr. Prativa Baral is building health systems ready for whatever comes next: pandemics, disasters, and emergencies. Through her research at McGill University, she's working to ensure that evidence and readiness go hand in hand. Please welcome Dr. Prativa Baral, presenting Faster, Smarter, Stronger, Building Health Systems Ready for the Next Emergency.
Hello, good afternoon. Thank you so much for this honor. It's such a privilege to be here and to speak right after hearing about the incredible work that so many of the laureates have done. And a special thank you to Dr. André Briend as well, whose work has inspired so many of us in global health. Oh. Okay. I'm just going to awkwardly stand here oh, here we are. Okay. So I'm going to start with a quote, and I think it'll land really well in this audience because it's a quote by a science philosopher. And basically the quote is one that I've been thinking about a lot. It's followed me through every health emergency that I've worked in, whether it's COVID, whether it's climate shocks. And it's the idea that when systems collapse, the question that everybody asks is, what's happening? And often we just simply don't know. So all of our knowledge is only some kind of approximation, and the approximation can be improved. We do not know, we can only guess. And my work has been about improving guesses during health emergencies. And rethinking health system readiness in the context of health emergencies so that health systems are faster through better data and evidence, they're smarter through better systems and workforce, and they're stronger through better trust and communications. So 6 months into my PhD, the pandemic hit. And so my PhD years were very much all about how do we make health systems faster? The answer to that, which might sound very simplistic because it's a lot more complicated than that, is that we need data and we need it in real time. The problem is traditional data cycles are slow, and in an emergency, you want the wheel that you're seeing on this slide to move faster and faster. And instead, the opposite tends to happen. By the time the right information has reached the right decision maker, the situation has already changed, and we saw that over and over again during COVID. Or you're collecting data once every 5 to 6 years with health facility surveys, for example, and they're great, they're comprehensive, but they're not really helpful during health emergencies. And so what happens then is throughout the pandemic, that's one of the things that I worked on. I worked with the World Bank and the GFF and partner countries around the world to try to find ways to improve this data cycle so that it was moving fast enough to guide decision making. As you'll recall, we were trying to figure out how to allocate resources accordingly, which regions were being most affected first, what was happening, and where do we act first. And so this is an example of some of that work. The graph shows country data, and because of data sensitivity issues, I'm not saying which country it is, but it's not Canada. And essentially what we were doing is we were trying to monitor how essential health services were being disrupted as a result of COVID. So on this graph, on the y-axis, what you're seeing is the average number of outpatient consultations per facility, and then on the x-axis, you're seeing time. So we went to countries and we said, okay, what data do you have that's trickling in to kind of get a sense of what's happening, what kind of service disruption is happening during COVID? And they had administrative data. So those are health systems data from dozens of countries, and we projected what we thought was going to happen based on historical trends, based on seasonality, and then in red, what you see is what actually happened. And as you can see here on the right square, what actually happened is that there was a 20% reduction, more than 20% reduction in service utilization in the peak phase of COVID. And this points to problem one, because most countries don't have reliable monthly data, especially during emergencies. And so as a result, more often than not, you're extrapolating. So let's say you're going in February 2019 and you're taking a snapshot of that particular period of time. And because you don't have data, you're kind of extrapolating to the future. And that's a problem, as you can see, during health emergencies. So we did this for a number of different countries around the world, for a number of different important indicators. And if we look at OPD, this is a paper that we published at PLOS Medicine. OPD, so outpatient consultations, the graph on the very left, this shows the average of the disruption in the partner countries that we were working with. So on average, what we saw was that there was a 13% drop in outpatient visits. And if we were to model that, that translates to over 113,000 excess maternal and child deaths during the pandemic. And so these numbers, the fact that there's a data lag, aren't just statistics. They're evidence of what delayed information costs. Because had we known that these services were being disrupted in real time, then maybe we could have done something about it to avoid service disruptions and excess deaths. So problem 2, I kind of alluded to that earlier, is that even if you have the data, if the data is incomplete, then that's not helpful either. You have biases, you're making assumptions. And this is another country that I was working with during COVID, and we can see that there are a lot of indicators that are either always unavailable with a massive spike in the lack of completeness in the COVID phase. So that's the blue graphs that you're seeing there. So my team and I wanted to do something about it. We realized that routine data can only go so far, and this is particularly true during an emergency like COVID, and yet countries still had to make decisions. And so we created a rapid data analytics system, what we conveniently called FASTER, or the Frequent Assessment and Systems Tools for Resilience, so that the wheel that I showed you earlier can move faster and faster. And so the idea with FASTER was to create a methodology that provides real-time pulse checks of what's happening on the ground on disruptions between traditional forms of data collection. And because we created this methodology during COVID, it was short, it was nimble, the questions that we were asked were adapted based on the country's needs and priorities at that time. And they were phone-based, which was very much a game changer at that point because it meant we didn't have to go to health systems. We could just do it via the phone. So we collected data frequently, we analyzed it in a timely fashion where we also automated a lot of the analysis because we were doing this on a monthly basis to a lot of countries. And then we shared that with country partners who would then figure out which health system gaps to prioritize. And then they would tell us what else they wanted and what else to investigate. And then we did this over and over again during the pandemic. And because of the smaller, constant, shorter pulse checks, we're not just receiving one snapshot in time, we're really measuring not just readiness, but also resilience over time, and really getting a sense of the trends of whether the health systems were absorbing the shocks or which health services were being disrupted. And the system, this methodology, is now being used in over 18 countries and more to monitor health systems and inform decision making. So I'm going to give you a specific example of the trend assessment. So this was some work that we did with a couple of countries also in the acute phase of the pandemic when vaccines were about to be available. And a lot of the government partners were concerned about vaccine hesitancy, and rightfully so. And so we were able to track the evolution of vaccine hesitancy across several countries. And what you see on the left are just the pulse checks that we did and the countries that we looked at. And on the right, because we were able to monitor it rapidly and quickly and frequently, we actually noticed that it was actually not a question of hesitancy, it was really a question of access, at least among healthcare workers, which seems very obvious to us in hindsight, but at that point in time, had we not monitored it as frequently, we wouldn't have known this as quickly, and this has massive implications, as you can imagine, for policy. So this is a small segment of some of the questions that we added and adapted. And this is to say that data is political, right? Health crises are political, and it's hard to measure during emergencies. It's really hard to do that well. And this is just to give you an example of additional questions, additional modules that countries had, because we were iterating this tool over and over again. And so whether it was vaccine hesitancy, whether it was questions about PPE, whether it was questions about childhood immunizations, we were able to add questions as needed based on the country's political reality, country's needs, and scale it across all of these countries during an emergency. So it was really interesting and stressful to iterate a tool and adapt it during an emergency and to scale it and find a way to balance core standardized questions so that we can still compare, while also recognizing that there were some very country-specific needs that we needed to address. And so these rapid cycle assessments are really helpful because they capture change in the health system, but also capture country context, which is really, really important during health emergencies. And FASTER, as I've mentioned, is now used not just for COVID, but to measure all sorts of shocks from violence to shortages in medicines or natural disasters. I'm going to briefly show you a small other example that's more Canada specific. So I'm a huge data nerd, as you can imagine. And so I firmly believe in the idea that better data, more frequent data is what we need. So this is an example of a project I was involved in with the COVID Immunity Task Force right here in Canada, where we were trying to build a network that was built on residual blood samples so that we can assess emerging and endemic pathogens that are emerging. And I know I'm running out of time, so I'll quickly tell you a little bit about some of the work that I'm doing as a new faculty at McGill. I joined in May, so very new. But this is this recognition that even if you have the best information and the best data, if you do not have systems that can act on the data, then it's not really helpful. And so we are thinking about this in the context of changing climate, and frequent climate shocks, as well as Canada's senior population outlook that has uncharted territory. So in that context, where our health systems right here domestically will be quite burdened, how do we help? And so this is a new project that we've just launched, and it's in response to the realization that the current emergency model is quite reactive, it's military dependent, it's unsustainable, and we saw that during COVID. And so we're building a future model of a civilian reserve that's coordinated, local-led. It's basically a surge system that would act to the data that's being collected, that's embedded in communities, and that would be ready to respond to across crises from wildfires to pandemics. And we have proof that this model can work. We have certain specific groups that have popped up right here in Canada. And we're working with a couple of partners from across the country and having initial conversations with the Red Cross to design the blueprint of this emergency reserve, looking at governance options, financing models, and workforce strategies so that once we have the data, we also have a responsive mechanism to act on the data. And then the final thing that I'll say is you can have data, you can have smart systems that can respond with a trained workforce, but systems fail when trust fails. And that's basically what we're trying to, one of the pillars that we're trying to navigate at the Pandemic and Emergency Readiness Lab at McGill. I'm co-leading that lab with the former international president of MSF, Dr. Joanne Liu, and we're essentially a research lab that's trying to strengthen health systems readiness with the data piece, the ones that I mentioned, with the workforce piece, but also the trust piece. And we're hoping to put all of this together in order to make sure that our health systems are faster, smarter, and stronger in preparation for the next health emergency right here domestically, but also globally. Thank you very much.